Before I start, this is a reminder from my prior talk regarding the classification of cancer therapy-related cardiac dysfunction. You have severe CTRCD, which means clinically severe heart failure requiring inpatient therapy or cardiogenic shock, or it could be an EF reduction to less than 40%, even if asymptomatic or moderate outpatient heart failure. Then you have moderate CTRCD, which is moderate clinical heart failure requiring outpatient titration of therapy but no inpatient hospitalization, or an EF decline to 40 to 49%, especially an EF decline by more than 10% to 40-49%, or less than 10% to 40-49%, along with other features such as a decline in GLS or a rise in biomarkers. Mild CTRCD is just a decline in GLS more than 15% or a rise in biomarker without a new clinical heart failure or a decline in EF to less than 50%. Severe and moderate CTRCD generally require temporary interruption of the drug, and the drug usually may be resumed once EF and heart failure fully recover. Mild CTRCD does not dictate drug interruption, but warrants closer surveillance and preventive therapy with ACE and beta blockers. Now I will move on to describe specific toxicities of specific cancer therapies. I will start with anthracycline toxicity, especially doxorubicin. The risk of cardiomyopathy is 3 to 26% with doxorubicin, less so with other anthracyclines. And this risk increases after a cumulative doxorubicin dose of 250 milligram per meter square, and even more so, much more so with 50 milligram per meter square. ACE inhibitor and carvedilol prevent some of the EF decline with therapy. An intracellular chelator, dexrazoxone, and liposomal anthracyclines should be considered in patients receiving cumulative doses over 250 or patient at high risk of CTRCD, as I explained earlier, because dexrazoxone and liposomal anthracyclines reduce anthracycline toxicity. Cardiomyopathy of anthracyclines typically occurs early on during therapy or within a year of completion of therapy. It may develop late, over a year later, but this late occurrence is often a progressive worsening of an early cardiotoxicity that was not promptly detected. Anthracycline cause myocardial toxicity because they cause myocardial free radical formation with subsequent myocardial necrosis and progressive myocardial injury. The anthracycline toxicity is the most irreversible cancer therapy toxicity. However, while traditionally considered irreversible, modern studies have shown that if treated early with heart failure therapy, less than 2 months after the end of anthracycline chemotherapy, EF fully recovers in 64% of patients and improves at least partially in 82% of patients overall. Beyond the 12 months, even partial EF improvement cannot be achieved. So, making the diagnosis early on within 2 months of therapy can lead to reversibility in up to 82% of patients. Making the diagnosis 2 to 12 months can lead to some reversibility. Beyond 12 months, it's too late. So, anthracycline toxicity is not irreversible, and reversibility is rather a function of early diagnosis and immediate treatment. So, how do you do surveillance in those patients? We should do echo-EF before therapy initiation and after a cumulative dose of 250 milligram per meter square to detect early toxicity. In high-risk patients that I described, such as those with underlying heart failure, cardiomyopathy, EF less than 50%, severe valve disease, or CAD, echo is also repeated every 2 cycles and within 3 months of therapy completion, regardless of the dose. And troponin and BNP are measured at baseline and before every cycle to detect even subclinical early toxicity before echo toxicity. Knowing again that GLS and troponin BNP abnormalities do not dictate anthracycline interruption, they dictate closer surveillance and ACE beta blocker therapy. Now, what's the treatment of anthracycline toxicity? Note that anthracycline therapy should not be initiated in patients with EF less than 30% and is preferably avoided in patients with EF of 30 to 50%, but it's not contraindicated. Depending on cancer treatment option for that patient, they may be used with an EF of 30 to 50%. This is for baseline initiation. Now, after initiation, once you get CTRCD with anthracycline, therapy is interrupted in cases of severe CTRCD, such as severe clinical CTRCD, meaning severe heart failure requiring hospitalization or shock, whether asymptomatic decline or a decline with moderate outpatient heart failure. Also, therapy is interrupted in moderate CTRCD, where you get moderate outpatient heart failure or an EF decline to 40-49%. Now, after you interrupt therapy, you may resume it once clinical heart failure and EF resolve and normalize. The only exception is if you develop severe clinical CTRCD with anthracycline, meaning severe heart failure warranting hospitalization. In that case, anthracycline therapy is discontinued for good. Otherwise, even if you get moderate CTRCD or severe EF decline without severe clinical heart failure, you may resume anthracycline eventually after heart failure EF recovery. And when you do resume it, certainly use heart failure therapy in conjunction, ACE beta blocker, and try to use liposomal anthracycline and dexrazoxane as recommended by the ESC guidelines. And once again, a rise in troponin or BNP or a decline in GLS or a new diastolic dysfunction may precede systolic dysfunction and clinical heart failure and indicate early toxicity, but they do not mandate treatment interruption by themselves. Now I will talk about targeted therapy toxicities. Targeted therapies can cause all 6 of cardiac toxicities to various degrees with various agents. 1. Heart failure cardiomyopathy. 2. Arterial thrombosis/MI. 3. Venous thrombosis. 4. Hypertension. And 5. AFib. And you have a 6th one, which is QT prolongation. VEGF antibodies such as bevacizumab and VEGF tyrosine kinase inhibitors cause hypertension very frequently in over 20% and typically over 50 to 80% of patients. So hypertension is very highly prevalent, particularly when you combine multiple targeted therapies. They can cause cardiomyopathy in 10 to 28%, so it's highly prevalent with VEGF antibodies. And they may cause arterial and venous thrombosis through endothelial and vascular injury. That's why they are associated with 1 to 10% risk of acute MI or severe CTRCD by EF. EF decline to less than 40% without necessarily a severe heart failure, and 1 to 10% risk of venous thromboembolism. And now, aside from VEGF antibodies and tyrosine kinase inhibitors, most targeted therapies, antibodies or small molecules kinase inhibitors, frequently cause hypertension. All targeted therapies, including those involving targets other than VEGF, may cause cardiomyopathy 2 to 10%, more so with VEGF inhibitors. Why does cardiomyopathy happen? Cardiomyopathy usually occurs early on during therapy, usually after the first cycle or the first few cycles, including HER2 therapy, again early on, after the first cycle or the first few cycles. And this is due to direct myocardial toxicity. Blocking those intracellular kinase pathways may cause contractile dysfunction, metabolic dysfunction of the cell, and cellular apoptosis. Also, cardiomyopathy may be due to that highly prevalent hypertension and afterload rise. They may also be due to coronary macrovascular and microvascular endothelial damage. Cardiomyopathy is overwhelmingly reversible with drug interruption in at least 80% of the patients. Arterial thrombosis, MI, occurs in 1 to 10% of patients. That's very high. And venous thromboembolism in 1 to 10% of patients, and even more than 10% with bevacizumab and anti-VEGF antibody. AF can occur in up to 5 to 10% with some kinase inhibitors. There are specific kinase inhibitors that can cause AFib, particularly the Bruton tyrosine kinase inhibitor used in CLL and B-cell lymphoma, such as ibrutinib, also with BCR-ABL kinase inhibitors used in CML, also with some VEGFR inhibitors, some of them, not all of them, such as sunitinib, sorafenib, used in renal cell carcinoma, and with most multiple myeloma targeted therapies. So those are the therapies that most prominently cause AFib in 1 to 10% of their use. And you may get QT prolongation with some of those drugs. What is the surveillance with those drugs? In general, most of these therapies require baseline echo, ECG, and cardiac markers. Then repeating those studies at 6 to 8 weeks after starting therapy, then every 3 months, especially in high-risk patients. Again, toxicity occurs early on, so that's why you repeat those studies at 6 to 8 weeks and every 3 months. And interrupting therapy early on can lead to quick reversibility. Specifically among the targeted therapy, we have the famous trastuzumab HER2 receptor antagonist. Trastuzumab inhibits epidermal growth factor expressed on some breast cancer cells. However, it also inhibits this growth factor on myocardial cells, and thus it risks reducing normal myocardial growth, repair, and survival. And that's what causes cardiotoxicity in 15 to 20% of patients and in up to 27% when it is combined with other cardiotoxic agents. It is mostly asymptomatic LV dysfunction, which progresses to clinical heart failure if missed early on. Whereas if you recognize it early on, it is usually and overwhelmingly reversible after cessation of therapy in at least 80% of the cases after a mean of 1.5 months. What surveillance do we do? It's kind of similar to the other targeted therapy. You need to do baseline echo, and you need to repeat echo every 3 months during therapy and 3 to 12 months after therapy completions. Cardiac biomarkers are measured at baseline and every 2 to 3 cycles. Treatment. When you get CTRCD with trastuzumab and with other targeted therapy similarly, what do? For severe CTRCD, meaning either an EF decline to less than 40% or severe clinical heart failure requiring hospitalization, and for moderate CTRCD, meaning an EF decline to 40-49% or moderate outpatient clinical heart failure, trastuzumab or other targeted therapy is held for about 1 month and EF reassessed afterward. Trastuzumab or other targeted therapy may be restarted if EF normalizes and clinical heart failure resolves, even if severe inpatient heart failure has occurred at one point. Unlike with anthracycline, where if you get severe clinical heart failure, you stop it permanently. Interestingly, trastuzumab or targeted therapy may even be continued in moderate asymptomatic CTRCD with the EF decline to 40-49%, but without clinical heart failure. And all those recommendations, I obtained them from the ESC guidelines, which provide nice charts regarding those drugs. A quick note about the special multiple myeloma therapies. In multiple myeloma, the following 4 classes of drugs may be used. Alkylating chemotherapy, the special immunomodulatory drugs such as thalidomide and lenalidomide, the special proteasome inhibitors, which are small molecule targeted therapies such as bortezomib. Remember, those proteasome inhibitors, they end in mib. And you have targeted monoclonal antibodies, targeted therapy anti-CD38, such as daratumumab. All those 2 to 4 therapies are associated with hypertension and elevated risk, 1 to 10% risk of heart failure cardiomyopathy, AFib. I mentioned earlier, multiple myeloma therapy can cause AFib, arterial thrombosis MI, and venous thrombosis, particularly those immunomodulatory drugs, especially that lenalidomide and the proteasome inhibitors. So those can cause heart failure, AFib, MI, and venous thromboembolism. A note about androgen deprivation therapy for prostate cancer. This therapy is used in multiple disease stages of prostate cancer, including metastatic cancer, but also localized prostate cancer as an adjuvant to radiation, and high-risk biochemical recurrence of prostate cancer after definitive prostate cancer therapy. And there are 4 types of androgen deprivation therapy. Again, this used to be very confusing for me, all those names. So trying to give you as much as I can classification of names and how those names end so you can recall them. So one, you have GnRH agonists such as goserelin or luprolide, which are intramuscular injection or sub-Q implant. Those GnRH agonists initially cause a surge of LH followed by suppression, and they may cause a surge of androgen before suppression, and that surge in androgen can cause cardiotoxicity. Then you have androgen receptor inhibitors. Those end in MIDE, M-I-D-E, such as apalutamide, and those are oral drugs. Proteasome inhibitors end in MEB. Immunomodulatory drugs end in MED, and androgen receptor inhibitors end in MED as well. Then you have androgen synthesis inhibitor, such as abiraterone, an oral drug for resistant metastatic prostate cancer. It is associated with a significant atrial fibrillation risk. Then you have GnRH antagonists. I mentioned GnRH agonists. You have GnRH antagonists, which cause more complete and rapid androgen suppression compared to GnRH agonists without the initial surge. One name is digarelix. It ends with lix as opposed to lead here. And those may be used in patients at higher cardiovascular risk because they don't cause that initial androgen surge. All these androgen deprivation agents are associated with increased risk of hypertension, adiposity, sarcopenia, diabetes, heart failure, and MI. Again, remember, heart failure, MI, hypertension, AFib, venous thrombosis, those five, we keep hearing about them. Abiraterone specifically increases AFib risk and fluid retention. The risk with GnRH antagonist is lower, hence GnRH antagonist is suggested in higher cardiac risk patients. So the androgen deprivation therapy is a high cardiovascular risk type of therapy. Now I want to comment in reverse and in summary. What are some of the therapies that cause atrial fibrillation? Atrial fibrillation is common in cancer patients and is partly due to cancer-induced inflammation and stress, metabolic abnormalities, but also some of the drugs. Chemotherapy, cisplatin 5-FU, anthracycline. But more importantly, some small molecule kinase inhibitors, such as the Bruton kinase inhibitor, BCR, ABL kinase inhibitor, and some VEGF, tyrosine kinase inhibitor. The multiple myeloma therapies that I mentioned here, all of them are associated with atrial fibrillation. More than 10% with melphalan alkylating chemotherapy and 1 to 10% with each of the other three, targeted monoclonal antibody, proteasome inhibitors, and immunomodulatory drugs. And abiraterone used in prostate cancer. Now, what are agents that cause MI and arterial thrombosis? Classically, you have 5-FU and its oral drug capecitabine. These antimetabolites may cause coronary macro or microvascular spasm within 2 to 5 days of drug administration and lasting up to 48 hours. And vasospasm is quite prevalent. It occurs in 3 to 20% of patients. This is a board question. You need to know that. 5-FU causes coronary vasospasm. So they show you somebody with chest pain and ST elevation after 5-FU therapy. And importantly, doesn't have to be during 5-FU therapy. It occurs within 2 to 5 days of drug administration, frequently after finishing the infusion or the bolus therapy. And it lasts up to 48 hours. It can last way after the drug therapy has finished. And they will show you that on board, and they will want you to know that this is coronary vasospasm, and this is treated with nitrate and calcium channel blockers, and sometimes preemptively use nitrate and calcium channel blockers, for example, in patients who have CAD who are at higher risk of vasospasm. Higher doses and continuous 5-FU infusion have higher cardiotoxicity than bolus administration. Coronary thrombosis may also occur, particularly after prolonged or refractory vasospasm. Then you have here, I will comment on the targeted therapy, which can cause arterial thrombosis and MI, particularly VEGF antibodies and VEGF tyrosine kinase inhibitors. Then you have the multiple myeloma therapies that I described. Those three kinds of therapy here, all those can cause MI. particularly lenalidomide and the proteasome inhibitor that end in MIB, and the androgen deprivation therapy in prostate cancer. Now, the final topic I want to describe is immune checkpoint inhibitors and the heart. Immune checkpoint inhibitor associated myocarditis has variable presentations ranging from asymptomatic troponin elevation with abnormal EKG, and you need to have something beyond troponin elevation to call it myocarditis. Asymptomatic troponin elevation does not define ICI myocarditis. So to be myocarditis, you need to have asymptomatic troponin elevation with abnormal EKG, or you may have non-fulminant clinical myocarditis presenting as ACS-like chest pain or mild heart failure or LV dysfunction. Or you may have fulminant myocarditis with severe clinical heart failure up to cardiogenic shock, or severe ventricular arrhythmia, or high-grade AV block, or sudden death. So those are the three types of myocarditis: asymptomatic, non-fulminant myocarditis, and fulminant myocarditis. ICI myocarditis is rare, prevalence up to 1.4%, but more common with ICIs, combinations, or with underlying cardiomyopathy. Also, subclinical cases, now that we recognize them, may be more common, and now that we monitor troponin and EKGs more frequently. At least half of patients with ICI-associated myocarditis have a normal EF on presentation. They present with troponin elevation and EKG abnormalities or rhythm abnormalities. A reduction of GLS is more sensitive for the diagnosis of ICI myocarditis, but the specificity is reduced, especially if other cardiotoxic drugs are used. ICI myocarditis is frequently associated with other autoimmune manifestations, including myositis and myasthenia gravis-like syndrome in 30% of patients with myocarditis. Myocarditis develops at a median of 30 days after ICI initiation, and in all cases in less than 12 weeks after ICI initiation, and has a high mortality of 17 to 30%. So when we give patients ICI, how do we monitor them? ICI-treated patients undergo baseline EKG and troponin measurement before treatment, followed by surveillance with regular troponin measurement every 1 to 2 weeks and or before doses 2, 3, and 4. Keeping in mind that ICI are given as cycles of intravenous therapy. If troponin rises, you do EKG and echo. But in the absence of a major EKG or echo abnormality, particularly an EF or GLS decline or arrhythmia, treatment is continued with close surveillance. You cannot call it myocarditis purely based on troponin rise. You need something else, EKG, echo, or MRI. In one study, over 10% of patients exhibited elevated cardiac troponin level, yet only 1.4% were eventually diagnosed with myocarditis. If troponin rises with any of the following, then myocarditis is highly considered. And what are the following? A clinical syndrome of chest pain, ACS-like, or dyspnea, heart failure-like. That's one. Number two, EF plus or minus GLS decline. Number three, EKG abnormalities. And you can have early EKG abnormalities such as ST abnormalities, depression or elevation, or diffuse T inversion, which is common with ICI myocarditis. Or you can have early conduction disease such as bundle branch block or PR prolongation. Or you get to the more advanced EKG abnormalities such as more advanced AV block and sustained ventricular or atrial arrhythmia, which are more consistent of a fulminant myocarditis at this point. So anyway, those are the three types of manifestations that you need with troponin to consider myocarditis and to activate the myocarditis diagnosis pathway. And when you have those, you do an echo if it wasn't already done, and you do cardiac MRI if you have it at your institution. And how do you make a definitive diagnosis? The diagnosis is based on cardiac MRI Lake-Louise criteria of myocarditis, fulfill T2, LGE criteria, and T1 increase of extracellular volume criteria. You need to have those two, and then you have an established myocarditis diagnosis. And the diagnosis is further corroborated if other immune phenomena, particularly myositis, are present, such as elevated CK and elevated acetylcholine receptor level, as in myasthenia gravis-like syndrome. If MRI is unavailable, the diagnosis relies on troponin rise and two of the following four: a clinical syndrome, chest pain, dyspnea, or overt heart failure; suggestive EKG, whether the early ones, the ST abnormality, or the early conduction disease, or PVCs, or the more advanced ones, particularly the more advanced ones, arrhythmia or new conduction disturbance. And the third feature that support myocarditis diagnosis is LV systolic dysfunction with or without segmental dysfunction in a non-Takotsubo pattern. And the fourth feature is other immune phenomena, especially myositis, myasthenia gravis, or colitis, hepatitis, pneumonitis, or dermatitis. So you check for all those. For example, you may have somebody with troponin rise, EKG abnormalities, and other immune phenomena. You made the diagnosis of myocarditis even if he's asymptomatic without a decline in EF yet and without advanced EKG abnormality. This is the asymptomatic early myocarditis. It is a definite myocarditis, but it is asymptomatic. That's the earliest stage. You may make a diagnosis in conjunction with some symptoms, some early heart failure. That's the non-fulminant myocarditis. Or you may make a diagnosis with an EF decline and mild heart failure. That's another form of non-fulminant myocarditis. Or you may make a diagnosis with shock or advanced arrhythmia, and that's the fulminant myocarditis. And this is a slide from the ESC guidelines of how you make a diagnosis of ICI myocarditis. I basically summarized it here. Now, how do you treat ICI myocarditis? Treatment consists of holding the immune checkpoint inhibitor plus initiating methylprednisolone high dose 1 gram IV daily for 3 days plus heart failure diuresis and heart failure standard therapy such as ACE, aldosterone blockers, and SGLT2 inhibitors, and even beta blockers if the patient is not in active heart failure. And perform daily troponin measurement to assess the steroid response. If the troponin does not decline significantly, meaning more than 50% reduction from peak within 24 to 72 hours, and or AV block, ventricular arrhythmia, or LV dysfunction, EF, do not improve despite 3 days of methylprednisolone plus heart failure therapy. So you give yourself up to 3 days of steroid and heart failure therapy. No significant improvement in troponin, and no significant improvement of LV, clinical heart failure, and arrhythmia. This is what we call steroid-resistant ICI myocarditis. And some reports suggest that up to 50% of ICI myocarditis is steroid-resistant. So what do we do in this case? We need to initiate second-line immunosuppression, particularly IV abatacept, which is a CTLA-4 agonist. Keep in mind that CTLA-4 is one of the target of immune checkpoint inhibitors. So they antagonize the CTLA-4. So using a CTLA-4 agonist will actually inhibit the T cell. It works opposite to the ICI. This is a protocol described by Dr. Salem where IV abatacept is given every about a week for 4 or 5 doses. And in this report, they suggest even using abatacept for all ICI myocarditis because of this prevalence of ICI steroid-resistant myocarditis. In patients responsive to steroid, clinically and by troponin level decline, after 3 days of very high dose of methylprednisolone, you initiate oral prednisone of 1 milligram per kilogram per day, and you taper it over 4 to 6 weeks by 10 milligram per week initially, while continuing to monitor for clinical and troponin improvement and stabilization, as ICIs have long half-life and those patients may have rebound of myocarditis. Advanced AV block is expected to recover with steroid or with immunosuppressive therapy, but it warrants temporary pacemaker or temp-perm pacemaker implantation. Now, After recovery from ICI myocarditis, could you reuse ICI? Keep in mind, those patients, a lot of them have advanced cancers and limited options. So it's a legitimate question to ask. So here are some ideas. ICI remains at its target for several months, and its immunologic efficacy persists even after interruption, partly through immune memory. And corticosteroids do not seem to diminish the cancer response. Therefore, you can find comfort in knowing that despite using steroid and trying to put a brake on the ICI response, the cancer may respond to the initial immune checkpoint inhibitor therapy. Now, after recovery of ICI myocarditis, ICI rechallenge is associated with a significant risk of myocarditis recurrence, but may be considered in the case of asymptomatic myocarditis after its recovery. Regarding more significant cases such as non-fulminant myocarditis or fulminant myocarditis, per ESC, the decision to restart ICI treatment after full myocarditis recovery and after full weaning of oral steroid therapy in 4 to 6 weeks depends on various factors, including the severity of the ICI-associated myocarditis, such as fulminant with shock versus non-fulminant versus asymptomatic. Again, with asymptomatic, you're more likely to be able to restart it. You also consider other cancer treatment options for this patient. You consider whether you are using ICI for metastatic cancer with limited option versus as an adjuvant or neoadjuvant indication. And you consider the ability to reduce to single ICI if initial toxicity was brought by combination ICI immune checkpoint inhibitors. So you may carefully restart ICI in select cases with limited other option, particularly if myocarditis was asymptomatic or mildly symptomatic non-fulminant.